Hi, Rosemary.
Hello, how's everybody?
Oh, Rosemary,
Slid in
always
the
great.
door.
Yes.
All right, we'll give it like one more minute because I know you guys have so much information to share. But
If we do, can we use the time for our or our on-time guests to just introduce themselves? We could do that within a minute.
the ones that are already in the room,
Yeah. Yeah.
let's see, it's hard for me to see because I don't have like faces in front of me.
Ro-
Oh,
Rosemary, since we've spoken, I've heard more people comment on the need for nursing as part of this process that we're looking at.
It's amazing, is
Yeah,
I had
yeah.
a student say to me yesterday, well, nurses don't get invited to the table. And I said, she's going to come to the hub meeting with me. I said, sometimes you have to invite yourself. She said, are there going to be a lot of nurses there? I said, no, probably you and me.
but we will focus on nurses, medical directors, lived experience. We're going to touch
Music to my
everybody.
ears. Music to my
Yes.
ears. Okay.
Yes.
All right, so why don't we get started? It's 12:01, and for the sake of time, everybody that's currently in the room, because I can only see like the panel, but I can't see faces. If you just want to, in the chat, sign in with your name and maybe where you're from, just so we kind of know who attended this presentation. So welcome to our Lunch and Learn Orientation to Spiritual Emergency and Mental Health Crisis Care with Dr. Chatlos and Janet Warner.
Excellent. So I am a resident or was a resident of Monmouth County. I'm down in Ocean County, but have a very strong affiliation with what you're doing in Monmouth. We are introducing what we call an AWARE program. Are we aware of religious and spiritual experiences and mental health crisis? Dr. Chatlos will introduce himself in a moment. Consider this a pretty fast forward orientation. We do these all the time, and hopefully you leave with more questions and want to talk to us. We will make ourselves available. But this is an orientation to something that is fairly unknown, but it's been around in the knowing, at least to the 1970s, when I will share my experience, but probably even before that. So Lynn, if you would, we'll look at the agenda and objectives. So we do have some learning objectives. We will at least touch on them and start it. Our intention is to introduce this as orientation, and there'll be a lot more detail that we can expand upon as you have questions to meet these learning objectives. There is much more training and orientation we can do. So what do we have next? We will do some introductions. We'll ask you some questions, and you could raise your hand or put a thumbs up on our questions. Probably most of you are with 8 dimensions of wellness. We are focusing in on that spiritual dimension. We'll ask you some more questions if you recognize these behaviors of anyone you've known or worked with. We will very specifically dive into the spiritual emergency term. We'll look at the V codes and Z codes that have been available. We will introduce the term moral and moral injury and show you some resources there. And then we'll close with what does help look like? And I'll do it from a personal experience that I did have a number of spiritual emergencies, was locked up against my will, force medicated, and I survived. So this is like my 46th anniversary of just using it to advocate and orient. So let's see where we go from here. So Dr. Chatlos, we can go back to the DSM just for a second.
Actually, that's the
previous
next slide. That's the next slide, Janet. So
okay. So all right. So how many are aware of the religious and spiritual problem in the V code? Any thumbs up? All right. Yes, Dr. Emily. Yes, Rosemary, you are. Are you aware that it's been in the Pew Research that at least 49% of Americans have mystical experiences? Yeah, I wasn't sure if your hand stayed up. Yes, I don't know. That was a head scratch? But it is there. The research is there that it does exist. They do not all result in spiritual emergencies or hospitalization, but it is a truth by research. Anybody aware of Dr. Stan Grof's spiritual emergency book from 80s?
Yeah.
Maybe, yes.
Yeah.
And then Dr. Lukoff, we'll see at the end, is also an expert in this area, and we'll show you his Spiritual Competency Academy. I'm going to assume you might not know about that. It is a full CEU accredited course that you can take. So if we go to the next one, Dr. Chatlos will comment on where is this in the DSM?
Yeah, let me introduce myself. I'm an addiction and a child and adolescent psychiatrist. I have a private practice in Homedale in Monmouth County, and I had recently been at Rutgers. So I've been around in New Jersey for a long number of years. And in my work with addiction, I got involved with just trying to look at and understand the nature of spiritual experience and the role in recovery. Primarily started by interest in AA, but it expanded to many other areas. Janet's referred to the V or the Z codes. These are, you want to click the next slide. There's part to this slide that these codes are under additional conditions or problems that may be a focus of clinical attention. So they're not diagnostic. They don't lead to anything that someone could bill for, but they provide information that is useful to highlight. It was introduced into the DSM-4, I think in 1994, and has continued. But one of the difficulties and why we're doing this is that psychiatry and mental health in general has, I would say it, actively avoided the role of spirituality in mental health care. Partly because many things, biases, but one of the main reasons is as soon as we say spiritual, people think religious. So from the beginning, I want to separate, when we use the term religious, we're talking about an institutional set of practices that operate within a community. But when we talk about spiritual, we're talking about a personal, individual, spiritual experience that connects us with something non-ordinary that you may call God, the divine, the source, a higher power, whatever. So that's one of the things. And then if you look at the literature, there's another term, religiousness or religiosity, that refers to people that may have a practice, like you may meditate, but not be Buddhist. You may pray and not be Christian. Those are terms that we need to at least separate in our discussion. Go ahead, Jenna.
Separate and include. So again, most of you on this probably are aware of the 8 dimensions. It's been out. It was not available when I had spiritual experiences. We're focusing on that spiritual dimension. And by the end of this hour, you'll see how much further we want to go with the spiritual dimension that was even announced in the 8 dimensions. So, and you know what? Click the whole thing until it almost finishes it. Dr. Chatlos will explain this.
So let me talk about what we mean when we say spirituality. I mentioned that it's a personal experience. There's 2 ways to look at the use of the word spirituality. Spirituality can be a general term that, if you go down to the bottom of the slide, is characterized by some of these features. There's a sense of connectedness. There's a sense of energy and vitality, a sense of wholeness or unity. There's often an emotional component. It may be peace, serenity, but it may also be joy or awe or wonder. And then finally, there's usually a meaning and purpose. So if you really look at it, a Super Bowl game has many of the characteristics of spirituality. It's connected, it's energetic, there's a sense of unity for your team, there's a joy, and there's a meaning and purpose to some degree. Events and life experiences capture this part of our being, but this is not what we're specifically talking about. What we want to focus on is specifically spiritual experience. And you can find hundreds of definitions. This is the one I like, and I'll explain why. Spirituality is the quality of the relationship to whomever or whatever is most important or supreme in life. Notice that it's a quality. What that means is it's real. Spiritual experience is real, but hard to put into words, ineffable. And I always give the example, try to put the quality of soft into words, and it's difficult, but it's real. It's also not a thing, it's a relationship. And it's a relationship with whatever or whomever is most important to us. It may be nature, it may be God, it may be the divine, it may be some other source, but it's what is the most important part of our heart and our soul. So the rest of this talk is really going to be talking more about specific spiritual experience. And go next, Lynn. And when we talk about a specific spiritual experience, we usually refer to these as non-ordinary experiences. Now, Janet didn't ask the group, but
We'll do that.
okay, she's going to ask you to think whether you might have had something that you would call a spiritual experience in your life, but it feels different than day-to-day reality. That's why we call it non-ordinary. There's an ecstatic mood. There's a sense that this is realer than real, a certitude, a sense of newly gained knowledge. It may include perceptual alterations to the extent of hallucinations. It may include voices. It may include physical bodily sensations of buzzing and tingling. And it usually is related to some theme, either a religious or spiritual theme or mythological, but there may be other themes that have that same set of characteristics. But what's unique about the spiritual experience, especially as we look at it from a mental health perspective, the thinking disorganization, as in psychosis, isn't present. The person can still carry on a description of what was going on beforehand. What happened? What do you make of this? The cognitive disabilities or deficits are not present with spiritual experience, and very rarely is there any sense of suicidal or homicidal ideation. So even though these may get intense, they may get frightening to us as practitioners, they're really not dangerous in terms of danger to self or others. And when someone has a spiritual experience, they may not know what's going on. We're not taught about it. And it may get emotionally intense, which moves it into what we'll say more about a spiritual crisis. And then a spiritual emergency is when it is so intense that we really start to lose control. It is frequently, as Janet said, often misdiagnosed as a medical or mental disorder. And that's really why we're doing this, to point out, to have people be aware that not only is it not a mental disorder, that treating it like that and mistreating it can be harmful. And one more click, then, that it's a missed opportunity for growth. And that's ultimately what we hope to develop, is that the spiritual core that seems to be universal to all of us, that is out of our awareness, appears to have healing characteristics. And we're really seeing this with the research with the psychedelics that are just dramatically showing usefulness for depression, anxiety, substance use, PTSD. So we've got current knowledge that is very detailed. So I think that will be it for me. Actually, go to the next slide. Yeah, this separates what we specifically mean. A spiritual experience is just a private, individualized experience that can be a source of awareness, purpose, or a new perspective of life. It may increase in intensity where there's a questioning, a confusion, a puzzlement that can lead to a change to how someone views life. It may promote an identity crisis that can involve feelings of anger, depression, anxiety, doubts, maybe even conflict with their religious ideation or their families, and a time when someone may question the meaning of life or their beliefs. Janet will say more, but often what promotes, well, I'll let her do that. Spiritual emergency, it may intensify even more. And it can be difficult to handle. It can look like psychosis. There can be a loss of reality. As I said, there can be voices, but the voices aren't usually negative. They're positive. Someone's sense of reality and ego may collapse, and they have an experience of a different reality, altered states of consciousness. And I mentioned the sensory changes. And often with a spiritual emergency, that person is overwhelmed. They don't know what to do with it. And if we're aware of it, and we'll talk about how to manage it, we can just provide a tremendous service. Next slide. Thank you.
So, spiritual emergency book. We asked earlier, anybody familiar with Stan Grof's work? This was an amazing find in the 80s for me. I had my first spiritual emergency in 1979. I went on to heal myself and went on to success in corporate America. But I found this book, and it was always behind my head, you know, am I bipolar? Did I really have it? And this nailed it for me because I saw the name for the first time. I had an inner knowing and peace about what happened, but until this book came out, I didn't have the definitions. So kind of maybe your thumbs up or comment, you know, have you had an experience, which might be very private, you don't have to, or have ever heard of anybody having something that would be called hyper-religiosity, religious preoccupation, talking about Jesus, Muhammad, Buddha. Is that familiar? Have you ever seen it or heard of it? I got some handshaking. I wish I could see everybody. But so let's again, orientation, you know, all we want to do is alert you to the terms and some of the resources, but what do these experiences look like, feel like, sound like? I'll go into detail from my experience, but Dr. Chatlos, I think you're going to take the next slide.
Yeah, I think in mental health, one of our first concerns always is the relationship and the appearance of spiritual emergency and psychosis. And to really learn to separate them can be complicated, but there are some basics that can at least direct us, put us in the right direction, that the spiritual awakening is usually sudden, short, episodic, and intense. Whereas the psychosis of bipolar, the psychosis of schizophrenia, there's a prodrome. There's a period of abnormal experiences leading up to that sudden loss of control in a manic episode. The spiritual awakening can have positive changes with a new understanding of life and enlightenment. So there's a positive outcome that's possible. With psychosis of a mental disorder, there's an altered sense of reality, but it results in distress, and it's more negative. The voices are more negative, more commanding, and there's less insight, where with a spiritual experience, there can be potentially more insight. The sense of connectedness, purpose, inner peace, clarity, and improved insight, as I said, can occur with spiritual awakening, but psychosis, there's much more impairment of overall functionality. A person with a spiritual experience or spiritual awakening can usually, if asked, because often they don't even tell that it's got this spiritual component, can describe things that have been going on that might be related, that might help us to understand more about what they're going through.
So we'll continue. Yeah.
Yeah. Next slide. This is just real quick. The DSM does mention a few other things about spirituality, but very minimal. In other cultures, spiritual experiences may be seen as special powers. They become the leaders, the medicine man. They may become the shaman in some of these cultures. So this is just to highlight that there's there's a context, an American cultural context that's
You can
part
hear
of
me?
it.
Okay, sorry.
Yes,
I froze.
Oh, okay. Next slide, Lynn.
So what might be the causes of spiritual experiences? I think there are many, and we still need to learn about it. For me, it was very situational, both at 25 and at 50. At 25, it was a young divorce I was facing, and it was against my values to have to face that. So that prompted first an awakening to address the fear, and then it went into fear of how do I handle this? And so in a longer session, I could go into the details. In 2005, it was situational, where I had a major business failure after extreme success for 20, 30 years. And I had to address it by myself without support, or I chose to. I was a single mom, and I was on my way back from recovery, really from a situation of business failure. And I wound up going through an awakening that turned into an emergency, again, from fear. So those are my brief experiences that it can be very situational without any pre or post conditions of mental illness. And I think, Dr. Chatlos, you might say trauma of some sort would be a cause. And we can go to the next slide.
Janet, I'm actually going to do something different, if you don't mind. I'm going to share how I even got involved in this. I was a resident in psychiatry. I did my residency at Bellevue in New York City. And one night, I wake up in a panic. I'm sweating. I'm short of breath. My mind is racing. I had been dreaming of a horde of women, crazy women, frenzied, chasing me. I calmed myself down. I went to bed. When I woke up in the morning, I was paranoid. I was going to be killed that day. I went to work. I saw patients. I probably said no more than hi and see you next week in order to get uptown to see my psychoanalyst, because I was in a psychoanalysis. I walked uptown with my back against the wall, just looking for who was going to attack me. I thought he had cameras in the office. He was going to call the police. But because we had a good relationship, I went. And within one session, he identified what had happened, that part of the unconscious, in this case, it truly was, whether you believe in it or not, the truly Oedipal conflict, because I had just started having a critical new love relationship. And in my family, sex was sin. So I was going to be attacked by my father. The other piece, over the next few days, realized that I was raised in a religious family. My father was a minister. Every morning we had devotions at the table. And in this breakthrough of unconscious, I emotionally identified with Jesus Christ as my brother. And so I had this paranoid experience that lasted 3 days. I went to hell and was born again. So those are the things. And that told me there's another world in there. I should probably pay attention to it.
So
And
just
this,
connecting.
and here, this is in the DSM. There are cultural concepts of distress with their own names that have psychiatric mental health symptoms. We should be aware of it, but there's nothing that relates to American culture. of a spiritually transformative experience. It isn't even included as a possibility in terms of the distress.
Right.
Next
Not
slide.
yet. Not yet. We're looking to get it in there. Yeah, V codes and Z codes are very important to me. In 1994, shortly after, I did find the DSM-4, and it was like gold, because on, I think, page 685, the religious spiritual piece is in there. It's a little paragraph. I then went on in 2005 to present to investors and business folks to say this code is not being used and it needs more attention. And then I did my confession on Wall Street to say I had one and I was locked up inappropriately. What's good now is that was 2005. We only had the DSM-4. We now have the DSM-5 TR improvement. And we will talk a little bit more about Z codes in just a moment. And we look to raise the attention that you can put clinical attention should be. And we have some good news as we proceed forward of how this is advancing 20 years later. This is an exciting one. I found this just a month ago that as of 2024, Z codes are billable. And I almost would love Rosemary to do a quick comment on this, because you were part of me finding this. And so just shed some light of why is this important that we found that the Z code is billable?
Because no one's going to assess for it if they can't get paid. It doesn't mean anything. And that's horrible, but it's true. So, and we're not educating anyone on this. And, you know, if you're in a practice, now I'm a psychiatric nurse practitioner, if it's not built, it's like nursing practice. And I know there aren't nurses on here, but, you know, there's an art of nursing that we could spend so much time attending and caring for a patient, right? And advocating for a patient. But if it's not billable, it doesn't even get charted. It doesn't even get noted. So how many times do you honestly see a spiritual assessment done either on a psychiatric unit, in a substance use facility, or any of those places? They just don't even do it. I mean,
So
we had enough trouble getting Esprit, right, for addiction. So this is not being done. So it just goes by the wayside.
So we're going to make it very well known. And again, it's been a great find that we can now say it's billable. When I was in the hospital in 2005 and I shared how I wanted to be treated, been through it before, 25 years before. So I now had my research. I had people bring in my research in, you know, behind the locked ward. And I asked to be treated by the V code. And the doctor pretty much, we call it the clinical gaze, said nothing, hardly reacted. And when he came back, I said, could you, by the way, reduce my lithium? I'm very sensitive. I'd rather not have it, but I had to take, I was required. What happened at the end of my asking him to treat me this way, he increased my lithium dose. So on my medical report, I was upped on my dosage, I think, because I was challenging it and requesting more. But again, it wasn't billable. People didn't know about it. So we're excited that we raise the awareness and it's a billable code. Let's see where we go next here. Moral. That was another exciting thing. I felt like I was morally injured at 25 and then 50. And the main reason is I had such a profound, true, very, very clear Holy Spirit experience, although it's not always, it's crosses religions. But I felt morally injured because no one would believe me. And that's including ministers, family, friends, and doctors. So Dr. Chatlos, would you just comment on the most recent part that moral is now coming out visibly with the APA? You're mute. Or
Sorry. There's been an understanding, actually, I guess for about 15 years, of something called moral injury. It really developed in work with veterans, but also first responders, healthcare workers, nurses, that just as Janet described, there's a deeper level of a person that is injured, so that many veterans, they're treated for PTSD and PTSD symptoms, but they don't get better. And often they don't get better because we haven't recognized the depth of the moral injury to the sense of self and purpose and meaning in life. So the APA finally just, this is just the announcement today in the New York Times, is including moral to the V code. So it will read moral, religious, or spiritual problem, to at least highlight and bring out this other area that we can include.
Yeah. So those are two big things that we can send you follow-up material past our orientation, but you've been informed. It's now finally coming out in the names and improvements on the DSM V code. So let's see where we go from here. So questions, if you want to, these questions are somewhat rhetorical. You can ask yourself, you can write in the chat, or if you want to unmute yourself and speak. What's your own common sense about how might being misunderstood or misdiagnosed, called bipolar when you're not really, which was in my case, how does that result in moral injury, and how do we prevent it? Like, we'll talk about our version, but would anybody want to write in the chat or comment out loud?
Or as any of you that may have had experiences in this area or with spiritual experience with patients that might be relevant. We're doing this, we're still early in doing these educational trainings, and we're really interested in your feedback to get a sense of where is it in the field in New Jersey,
So Lynn, I can't see everybody. I'll read, there's a stigma where patients are not comfortable to be fully open. Yep, absolutely. We keep I've interviewed hundreds, and just recently at Greystone State Hospital, the person said, I am not talking, I didn't, and I'm not going forward because I get in trouble when I start telling the truth.
Another thing I tell people that when in medical school, we're young and they have to teach us to do a sexual history, and that's always difficult. But doing a true spiritual history is as intimate as a sexual. People will guard against it and get very suspicious. Why do you want to know that about me? So we have to realize that it's guarded, it's protected because it's so important to people.
Yeah. I see it makes people feel as though they're crazy. If they're, to be able to speak their truth and live their truth. In our docuseries, we cover this, and there are a lot of professionals with PhDs, MDs, MEDs, who have shown that to us, that they start feeling crazy if the professionals working with them, so we relate to that, don't acknowledge it. So please keep writing, because we'd like to look at this, but we're going to keep watching our time. We'll go for,
Yeah,
Dr. Emily.
Yes.
I
Is
really hate
Dr.
the fact that Janet and Dr. Chatlos invited me to this, because now I feel like I have to talk, because they know that I can't keep my mouth shut after all. But Greystone Park Psychiatric Hospital is one of the 4 state psychiatric facilities within the state who take obviously our sickest of sick of patients. And since 2010, we have been interviewing and collecting the data. I'm not allowed to share that with you. I'm sorry. I'm a state person. On the engagement that we have with the assessing of all of our patients that come through the front door of Greystone regarding their religious experiences as well as their spiritual experiences, because like what Dr. Chatlos and Janet are speaking about is so relevant and so underutilized and underspoken about that. So we've been collecting this information and treating our patients accordingly, and helping them work with their psychologist and their psychiatrist and their team in order to get the proper treatment, so that they're not over medicated, so they get engagement and interventions, they get to go to their religious programs. We want to ensure that people are holistically treated from the eyes of the spiritual realm. That being said, it's so unfortunate because most hospitals don't understand the necessity of treating the whole person. Because we don't actually inside the hospitals, including a general hospital setting, we don't feel like the chaplains make money for us. And so that's why your chaplains are very basic people on your team in many cases. In some cases, they're awesome. Hear that. But for a lot of the hospitals, we don't utilize our chaplains for the brain power that they have and for the engagement that they could be participating in. So I'm so excited that Dr. Chatlos and Janet I'm just excited that I found them and they found me, and that we've begun to, I can see that we're really working within the hospital programs at least. And then how do we get our, like you said, I'm sorry, Rosemary, about, helping people in the individual local practices help treat people with spiritual and moral injury issues.
Thank you, Reverend Emily, because there is, there's always these openings. Once we raise the awareness, members of the Wellness Center have access to talk to you and your team of chaplains, which is what we want to open up. So more on that to come in when we do part 2. So where are we next, Lynn?
Rosemary has her hand up.
Oh, sorry.
No, that's fine. I was just saying, nice to meet you, Reverend Emily. I was talking to Janet the other day, and I said, I'm going to try and do a present at the Psychiatric Nurses Association. I'm submitting an abstract because I think this is so important, and that nurses are, largest group of healthcare professionals, a lot of face time with patients. But the problem is when all you have is a hammer, everything looks like a nail. And what I represent is addiction. And I had to tell the steering committee, how did I think this went with addiction? I said, the problem is they're using a hammer and this is not a nail. That's what the problem is. It's a whole different, picture of a patient. And we don't do this kind of assessment. So patients just get cattle called into what we do for everybody. And this is something that's very special, with special symptoms.
Excellent.
So
As we
I'm
go,
gonna
And Rosemary, this is what we would call transdiagnostic. The spiritual component really crosses all aspects of diagnosis in some way or another. And I think Reverend Emily will definitely agree with that. You see it more than we do.
So as we go forward to the next slide, yesterday at We Are Monmouth, we talked about how can we introduce this to the chaplains throughout Monmouth County. So it's growing. This is going to lead us to, well, how can we help? And I'll do it very personally and somewhat generically. We already know, if there's no imminent danger to self or other, then we don't necessarily have to go call the police or, all that stuff. We can stop and listen, and we can listen for religious and spiritual themes and not overreact. Stay a little open-minded. Okay, the person's calling for Buddha, Jesus, Muhammad, their Bible, the Quran. So, all right, so now let me be open-minded, not judge it as mental illness from off the bat. Let's ask some questions, ask how can we help, who can we call? And one of the people we're actually talking about for a good year and a half now is ask if you can call their clergy or some faith leader. Do you want a faith leader here? And if you don't know one, let's provide one. And that might prevent both the expense of all these trips to the hospital and the moral injury that can result from it. So we're really advocating, can we just call it, would you like us to call a clergy?
I don't know how many people realize, but in Monmouth County, there are police chaplains. There is a training program for chaplains to work with the police. So there's a ready resource, even in the law enforcement, if we can find a way to use that.
Yeah. And that's where we're going to go next for our orientation. So we'll do a few levels of what does help look like. Some of this is just generic to any mental health scenario or crisis, but humbling ourselves would be great. And that goes for family, friends, anyone who's addressing a scenario. We all know empathy goes a long way. Listening, a true listening ear with questions. What's going on? What do you think is going on? And having some patience so we don't have to run right to an emergency center. How was I handled in 1979 as a college student and then as a businesswoman in 2005? I was not met with humbleness. I could tell on both scenarios, people knew what they thought they knew, and that I'm acting, not quite like myself, and that was true. But there was no humbling to get into some empathy. Oh, we realize you're going through a divorce or you just had a business failure. Normalize it. That was real normal. And nobody ever raised that. There was very little, if any, listening and inquiry to ask, what do you think's going on? I would have said it. And then patience to give me some time, because it's very hard to explain when you go into an altered state. We probably know near-death experience the easiest. I did not have that. But that's a very startling experience. It takes a while to be able to explain. So do all these other forms of spiritual experience. So you need some patience to say, well, give me some time and we can talk about it. What I wished would have happened is some awareness of spiritual experience. So it's like, oh, okay, this is what's happening. Yes. When I cared for, I had two very specific spiritual emergencies that I cared for. One is where a minister called me in because he wasn't comfortable. And there was an awareness that I knew. And very simply, this person would have been in what you might call religious preoccupation or hyper-religiosity. But she happened to be in a house of spiritual worship that was actually okay. That was normal for her. It was just a little extreme. So I asked her, are you aware you're having a spiritual experience? She said yes, gave her time to speak about it. I asked if she's eaten lately, just needed to have some basic food to ground her. My voice was very calm and open to her. On another one, I also, just did some very simple conversations to say, what do you see is going on? And we can kind of go to the next session because we get specific around, I had no fear of it, but many people, when they see this happen, family members, friends, even clergy, if you're not aware of it, there is a fear. So what gets in the way? This is an introduction to one of our partners out in Illinois. Dr. Olivia Johnson owns a Blue Wall Institute service where she cares for first responder mental health. She's partnering with our whole agenda and assisting with some of her thought about, well, what gets in the way? And I think these really fit well. What did my mother see when her daughter was in a heightened state of awareness? Again, no harm to self or other. She was frightened. She was probably embarrassed because neighbors saw me like dancing around in the backyard a little bit. I was like too happy. She was very apprehensive of me. She did not trust that I wasn't like off my rocker. And she was resistant to hearing anything. So even though I shared research with her, it was just too much. She just was resistant. What I would have loved is that she said, well, let's have some fellowship here. Janet, would you like to sit down and have a cup of tea? Can we sit on the couch rather than her looking at me from afar? Could she have empowered me with, I see that you just went on Wall Street. I see you've done all this research. We didn't pay attention to you. Give me some sense of empowerment, even as a businesswoman who's trying to do something right here. Approachability is really kind of, to me, a soft, warm, and gentle approach. The voice has to get calmer because there is such a heightened sensitivity, and to be responsive to what I or the other person is offering. So we're looking to use this fear model to say, we got to get out of our own way and just start getting somewhat comfortable or disciplined when people have these religious or spiritual experiences, does not necessarily mean call 911, doesn't mean they're mentally ill. It's real. So we'll see where we go next. So we've been doing this for now 1.5 years. We intend to do it more. We do believe the state of New Jersey can be amongst the first in the nation to start to install simple behaviors. And we do talk with all members of the care team. To the individual, one of the things is, do you sense something spiritual or religious is happening? That's a different question than accusing them of, you know, being out of control, call in a religious leader. So it's a question, do you sense? And then that's where I got to give a little time to the person.
And
But she
Janet,
Yeah.
let me add something that I was just thinking about with the last slide. We're going to be seeing a lot more people experimenting with substances like mushrooms, psilocybin, and whatever. So in addition to, do we sense something spiritual or religious? Don't forget to add, have you been taking anything in the last few days or weeks? Because that there is private about that these days, and we're seeing more of it.
Right. And that is a part of when we go into the training, you know, asking that question, and that is, you know, that's a stimulus for spiritual awakenings and or out of control spiritual awakenings. So asking that question just calms it down. It starts to include the individual. I really like number 2, because I wish in 2005, when I was taken by the police to a psychiatric hospital, that someone, at least the police, someone would have said, wait a minute, do you know there's a V code that she's kind of in that category? As a matter of fact, she just told me about it. Like, to friends and family, letting them know that it sounds like this is something that we could talk about in therapy, because there is that, you know, that offering is there. But we also went, when we spoke to first responders around the country, we said, worst case scenario, if you have to bring the person to the ER, would you advocate for them and say, there's something we're noting of a spiritual religious nature. It is a V code. Would you put that in the medical report? That's what didn't happen to me. It doesn't happen to hardly anybody. But if we alert the first responder teams, they can advocate, and at least there's a chance in the hospital the person might get attended to. Dr. Chatlos, you raised the thought of, let's also see if we can influence the mention on discharge papers, because in my medical report, there's nothing of religious or spiritual nature whatsoever.
Yeah, if it's identified in any institutional, whether it's inpatient, residential, or even a PHP, there's a discharge summary that goes to someone else in a handoff. If the V code, religious or spiritual problem were just included, just that, whoever picks up that case is going to think twice and say, why did they put that there, and start investigating it. So it can have it's minor, but it can have a significant influence on follow-up care.
Yeah. So here we go. We're coming to a close, and then we'll really engage a little bit more in questions and comments on this. So some of our next steps is a very grassroots initiative. Dr. Chatlos and I are leading in New Jersey, but we do have a team across the United States and across the world in many countries where we are influencing what they can do in their communities. We are going into the 3 state hospitals. We've gone to Trenton Psychiatric Hospital, Greystone, and we're going to Ancora. And it's specifically in the Wellness Center with CSP&J. We would love to go into more hospitals. So if you have an introduction to get into another hospital, send us in. We do an orientation. And that's with, right now, it's the members of the Wellness Center or patients. It can also be with medical doctors, nurses. We are offering, it says 4 to 6, it's 4 to 8 hour or training. So we go past this, and I know Rosemary's encouraged us. We're going to try to get CEUs connected to it. We will offer one-on-one coaching. Dr. Chatlos and I are available to talk with you off here. Please keep putting your questions in if you need to, but we can talk one-on-one. We are also investing in a docu-series that we're setting up for mainstream, and we've recorded hundreds of hours so far in the last 5 years of stories around the world, including experts. So we have the research, the experts, professionals, caring, and then lived experience. So if you're interested to speak in it or comment on it, we can do that. Dr. Chatlos does a lot of research and publishing. If you would like access to that, you can ask. And if you'd like to even consider co-publishing, I think it's something Dr. Chatlos is always looking to document. And any referrals you can give us, even if it's to a single person or a small agency or a large mental health corporation, we just want to keep doing the orientations to get that out. On the right side are some resources. We've done 3 first responder webinars around the country, so you can kind of see similar earlier material from last year, but it is with a first responder community. We want to do that in Monmouth and New Jersey. We really kicked this off in November 2023 when we went to Rutgers Medical School. And Rutgers Medical School exposed all of this from the psychiatric care view, and that video is also available on that link and on my website. Dr. Chatlos, you and I have spent some time with Dr. Lukoff, one of the experts. Would you comment about the Spiritual Competency Academy and how you feel about that?
Yeah, the Spiritual Competency Academy, it's a website, but they've got materials almost for anything we could think of. How do you do a spiritual history? How do you look at it? How do you understand it? How do you intervene with it? And it does give CEUs, it's fairly formal. And it's so far, I think, one of the best resources when we're really looking at the broad overview of especially spiritual experience in mental health. Dr. Lukoff himself publicly describes some of the most incredible, out of control spiritual experiences that he had in his life.
Yeah.
And yeah, so
you
that's a good
some
resource.
resources are there. We do open it up for one-on-one after this, but I think our next slide is just asking, how can we support you? Please put it in the chat. How can we go further? What else do you need? How was this helpful? What do you want to know more of? So Lynn, I can't see everybody, but do you see anybody that would like to? There we go. Perfect. How can we help you, in your own cause, in your own organization, and your own personal learning?
Well, we didn't get a chance to ask, have some of you seen experiences like this or heard of experiences like this with your clients? Or is this still something that they're keeping quite private?
Yeah, how familiar is this?
I
Lynn?
would say in my years of experience, and I've been around the world and every, practice from, special education to nursing, mental health, substance use. And so I think it's still very new. I feel like it's like, when we started to ask more questions, right? Are you a veteran? Like, that's still new to some case management agencies. So to add this to the list of questions when you're doing an assessment with somebody is extremely important. And so, my mind's spinning, like, I feel like you should present to our SRC, which is our system review committee. That's all of our hospitals here in Monmouth. I've already asked you to come to our professional advisory committee and do a snippet to say, hey, we can come and do presentations. I thought about Christine, who oversees our disaster response crisis counselors. This will be an excellent training for them. So like my mind is spinning. How do we get the information out there so that we start to ask the questions? So I feel like it's still a little bit new, but I think, our job is to raise awareness. So I see
Then the other thing is with adding something, one more responsibility to an assessment, people don't realize in less than 5 minutes, I can do a spiritual evaluation and get a true sense of where are we with this, in this, what role does it play, and how important do I need to pay attention? So
Yes.
it isn't anything, and we've got structured questions they can ask to get you right in, even though the patients are often hesitant. But there are ways to ask the questions that open that up.
And
it's not time consuming.
that would go into probably more of a 4-hour training and the age,
Yeah.
but we are offering at this point, you know, these 60-minute sessions. We probably could even do a shorter one in 30, but we're very motivated to do the orientation first. And then where people want more, we have to be clear. There's a lot more skills, competency, and practical application. Yeah. Yeah.
So, I just wanted to also say that if you're in a general hospital setting, it is Joint Commission mandated for every patient that walks through the door to be asked if they would like religious support. Like, that's the weird question. It is Joint Commission required, but it's not the right question. It is, would you like religious support? And so, you know, most people say no. Some people answer the question, but good portion of the people, you know, they're coming in for like an hour for a test or whatever, and they say no. And then that stays on their medical record unless they re-ask the question, and then it could change. But it's, in my opinion, it is not the correct question to be asking.
What's the question?
Well, I mean, it could be anything different than, you know, it could be something like, do you think that your spiritual needs, would you like your spiritual needs to be met while here in the hospital?
Yeah.
Or because like when my daughter was in the hospital for 4.5 months, they kept asking me, and I'm the director of a chaplaincy department, mind you. So, and they kept asking me for if I wanted a chaplain to see my daughter. And I kept saying no, because I did not want their staff to come and meet with my child. I did not need her to be prayed for. I needed myself and my spouse to be talked to. Like many people here, do you want to see chaplaincy? And they automatically, or do you want pastoral care? Like, let's go back 10 years and say, do you want pastoral care? No, I don't need a pastor. I want somebody who's going to talk to me about what I'm struggling with.
Yes.
So I would always say, because I am me, I would like to talk to the social worker or the psychologist or the, you know, any of those professionals, because for me, I knew that if I got a chaplain upstairs, they were going to talk to me about my daughter who was dying. And I didn't want to talk about that. I wanted to talk about like her life, her future. So I think that the way the question is asked and then is limited because most of the chaplaincy in-house programs are not paid. They are volunteer. They are not fully trained. They are clergy that come in who have no training on psychological stuff. So I can hijack Janet and Dr. Chatlos another day. But I think that the question needs to be asked differently.
Excellent. So we're going to add that to make sure we have like the really useful questions into the training to go past what we did on our orientation. In 2 minutes, please put anything else in the writing chat so we capture that. Would anybody else like to speak before Lynn closes this?
No, I just
want to know how we can help.
I think that the whole thing is you have to normalize the conversation like we do with everything else. I mean, we normalize sexual abuse, we normalize substance use, maybe not enough. With this, though, I really believe verbiage is, because it's like, it's just like, you can't ask somebody a question like you're asking them if, you know, if they went to Wawa for milk. You know, this is personal. Everything's personal. So I think that's a great, you know, how you ask the question. Always that you're going to get the answer on how you ask the question, right? And the idea is that I think you should do grand rounds. You know that. I have to see what I could do to get you to do that, because I think grand rounds at Hackensack would be great because they hit so many people. But I think normalizing the conversation, I will do that with my nurses. I think that a lot of people go in the hospital. Our goal is to keep them out of the hospital.
Yes. Yes.
You know, so I think that we do it, like I work in drug treatment. I mean, this kind of, you know, I think this is important that we keep them out of the hospital. That's the goal.
And give some sanity if we are in, because some of us do get caught. Lynn, we're gonna hand it back to you to do a close.
Well,
We will
let me
do follow-up.
let me just ask all of you. We're sort of starting at this. We really would appreciate feedback that you may give to Lynn in terms of how this was helpful, how it might be more helpful, because we're not sure what's out there and what you're seeing and what your needs really are as we try to develop our trainings.
Lynn?
Before I close, I have one more final thought for you guys. We have a crisis receiving stabilization center that's coming here in Marlborough very shortly. And I'd like to connect you with the folks that are heading that up from Robert Wood Johnson, because this is going to be a 24-hour, that's it. You come in, you go, but I feel like this needs to be added to their assessment so that they know how to properly help people get linked to the right, care. So anyways, with that being said, I love that everybody showed up today, the new faces, the faces that show up every month, and looking forward to see everyone again next month. And I'd like to thank Jana and Dr. Chatlos for this amazing presentation, and I hope everybody has a wonderful weekend.
Thank you, thank you. You can
Thank
share
you
the
all.
slides. So everyone can get the hard copy of the slides too. So thank you, thank you.
Yes, if you want it, I can send it to you.
Yeah.
Thanks, everyone.
All right.
Thanks.